Okay, welcome everybody. Today we'd like to welcome Gabriella Avellino to give us grand rounds on the management of priapism. She gave us a couple of topics that were in andrology, and I thought this would be a nice review for the group because we all have to deal with it, unfortunately, when we're on call, and usually we get calls. I think an update would be appropriate. Dr. Avellino did her undergrad at University of Pennsylvania and then did her medical school as well as her residency at Boston University, just like myself. And she then did a fellowship at Brown with Mark Sigmund and has stayed on as the fellowship director. She is from Connecticut originally, and she is looking to possibly join us down in the Greenwich campus. So, Dr. Avellino, please.
Good morning, thank you. My name is Gabriella Avellino, and I'm going to be talking to you today about priapism. Really, the impetus behind this is that the AUA guidelines just updated the management of priapism in 2021. But the difference this time was that they really just focused on ischemic priapism, and then they promised that they would be coming out with future recommendations for high flow and stuttering. So we're still waiting for that, but hopefully that will be. So I have no disclosures. And my goals today are to help you recognize, diagnosing the different subtypes of priapism and be familiar with the non-surgical and surgical management of ischemic priapism. So it's 4 a.m. Ding, ding, ding. It's your favorite pager calling you, and your favorite resident in the ED that says, call the ED back immediately. There's a guy with an erection. So your first thought is, thank you for all the details. Your second thought is, I hope this is not an inflated penile prosthesis. And then your third thought is, maybe this really is priapism. So what are the different types of priapism? There's ischemic or veno-occlusive low flow. This is a non-sexual persistent erection with little or no cavernosal blood flow. Typically here, only the corpora cavernosa are rigid, actually, not the corpora spongiosum. This does account for most of the priapisms that you'll see. And then there's non-ischemic, or also referred to as arterial or high flow. This is also basically unregulated cavernosal inflow. And this is neither painful nor a fully rigid erection. And most commonly, this is due to some sort of trauma. And then there's stuttering or intermittent priapism, where basically there's periods of ischemic priapism or unwanted, prolonged, painful erection, intervening with periods of detumescence. So in all, ischemic really is emergent and should be treated immediately. Non-ischemic is non-emergent, but you may consider intervening. And then stuttering obviously is a mix of emergent and then trying to focus on prevention. So priapism is named after Priapus, the Greek god of fertility. He is a minor god. He unfortunately was cursed by Hera with when he was still in the womb of Aphrodite. He was cursed with impotence because Hera was upset that Paris chose Aphrodite over her. And so you can see here that he's holding up his penis with a string and a stick. Unfortunately, not a very good erection treatment, but alas, that is where priapism comes from. So, as we discussed, typically priapism is defined by greater than 4 hours of painful erection. And then, actually the incidence overall is pretty low, even though in our lives it feels like it's more frequent because we do get this a lot. It is certainly more common in patients with sickle cell disease. So the evaluation and management. Typically you go through this pathway of, doing a history exam, maybe getting labs, imaging, and then treating. For ischemic priapism, because it's more emergent, you're going to have an overlap between treatment and, doing additional workup. So for history, you want to, learn the duration of the erection, the degree of pain that the patient's in. Do they have any history of this previously, and how is it treated? What are their medications? Have they recently, had any substance use? What was their sexual history? Did they have any trauma? Or is there any history of sickle cell disease or concern for, cancer or some other hematologic abnormality? You're going to examine the patient. I always just kind of, when they're in the emergency room, just hook them right up to the monitor, especially if you're going to be, moving on to phenylephrine injections. But you're going to do a general exam, and then you're going to do a more focused exam basically, assessing the rigidity of the penis and checking for any signs of malignancy or trauma. So for labs, really outside of sending a corporal blood gas, all of these other tests are really just adjunctive tests that you're going to be doing simultaneously and should not be holding up treatment for ischemic priapism. So labs that you want to consider are CBC, really to rule out possibility of malignancy or infection. Get a reticulocyte count, which may be elevated in patients with sickle cell. Consider hemoglobin electrophoresis, not just to diagnose sickle cell, but also possible other hemoglobinopathies such as thalassemias, especially in Caucasian patients. You're going to screen them for psychoactive medication screening and send a urine tox because, of course, everyone loves to deny use of any sort of substances. And then for really most patients, you're going to want to send off a corporal cavernosal blood gas. It always confuses the nursing team when you say send this ABG and they're like, where's it from? And you say from the penis, but just send it. And that's also kind of like my little trick of it's like your first treatment of aspirating a little bit of blood. Imaging to consider, but usually not necessary unless there's questions or confusion, is ultrasounds, pudendal arteriograms, penile arteriography, and penile MRI, which we'll talk a little more about. So again, when you obtain a corporal blood gas, you're going to aim for between 9 and 10 o'clock or 2 and 3 o'clock because you want to avoid the dorsal neurovascular bundle and the urethra. So you're going to just puncture in through there. When you get that blood gas back, so for an ischemic picture, you're going to see, an acidotic, hypocarbic, and low oxygen, whereas if it's high flow, it's going to be an arterial picture, whereas if there's no concern for priapism anymore, you'll see return to like a mixed venous blood gas picture. Doing an ultrasound really best for if there's kind of confusion over the possible diagnosis, or if you're trying to see the cause for high flow priapism. Really important to frog leg or have these patients in lithotomy position because you want to check the perineum. Because oftentimes, especially after a straddle injury or some sort of trauma, that will be where you may see the fistula or pseudoaneurysm down below. Oh, and sorry, I've highlighted in blue kind of like the updated AUA guidelines that came out. But so really recommended only if diagnosis is indeterminate in the acute setting. But obviously it will show for acute ischemic priapism very low or no flow through the cavernosal arteries, whereas if it's non-ischemic or high flow, you'll see normal to increased arterial inflow. In the non-acute setting, as I mentioned, you may get this if you have high flow priapism to, again, identify the abnormality causing it. The other imaging options, the pudendal arteriogram, really only used if you're planning embolization for a high flow priapism because it's invasive. And so, that will end up showing you where there's blush at the site of injury to the cavernosal artery. MRI, kind of newer out there, obviously expensive, not always available and time consuming. So, certainly a limited role in arterial priapism, but now becoming a little more commonly used for ischemic priapism, basically to show non-viable smooth muscle and to predict future erectile function. And the kind of evidence behind doing this was a study, a while ago, 2010, where patients presented with ischemic priapism, they all had an MRI. 23 of them ultimately also had corporal biopsy that basically confirmed the imaging findings that, when the MRI suggested that there was no smooth muscle viability, that it was 100% sensitive in diagnosing that. And then the opposite, that all patients that had evidence of smooth muscle viability, even without corporal biopsy, confirmation of that, did go on to have normal or some sort of preserved erectile function. And so here you can see T1 and T2 images. On the right is the T2 image showing that there is no gadolinium, showing no enhancement of the smooth muscle. So here, you know, unfortunately, there's no chance of future erectile function. So back to the emergency room. You go see your patient. It's a 66-year-old Caucasian man with painful erections for 5 hours, significant history for depression, and currently using trazodone. On exam, he's pretty uncomfortable appearing, but otherwise well appearing. And his penis is circumcised and it's completely rigid, corpora cavernosa, and very tender, but no evidence of trauma or malignancy. So, of course, the ED helped you out. They sent off a CBC, nothing concerning. They had done a urine tox that was negative. And then you do, you know, a little aspiration to send off an ABG. And what is your diagnosis? Perfect. So ischemic priapism, basically a compartment syndrome. There's a derangement in penile hemodynamics causing veno-occlusive mechanism abnormalities and acidosis of blood, leading to a very deoxygenated acidic environment. This then leads to impaired smooth muscle function, endothelial cell dysfunction, and PDE5 dysregulation. And then ultimately, you know, the unfortunate outcome if this persists is that you get smooth muscle necrosis, collagen deposition, and penile fibrosis, and ultimately erectile dysfunction. The causes of ischemic priapism are pretty vast. You know, there's idiopathic, as we discussed, you know, other hematologic dyscrasias, infections, kind of fear, spider bites, metabolic abnormalities, neurogenic causes, cancers, and then, you know, probably the most frequent of what we see, which are medications. Pretty common actually after intracavernosal injections with vasoactive agents. Up to like 30% of patients can experience this. So always want to warn them of that. But even alpha blockers and anticoagulants have been associated with it. And then of course, you know, we'll frequently see trazodone and other antidepressants and antipsychotics. And then of course, recreational drugs, you know, especially cocaine. So just briefly, you know, what about Viagra? We always warn patients whenever we prescribe PDE5 inhibitors that priapism can occur. It actually overall is pretty rare with these medications. There was a recent publication kind of reviewing reported adverse events with Viagra, which there were only 411 cases in a 20-year period, which is pretty uncommon. I mean, probably underreported overall, but really just keep in mind that antipsychotics, especially trazodone, and intracavernosal injection agents are actually a more common cause of this. So treatment. The goals of treatment are to return the penis to a flaccid and non-painful state. But just remember that even after treatment, you can still kind of have that like woody feeling, you know, penis with ecchymosis, edema. And so it kind of sometimes can fool you. Even though it is actually resolved. And so, you know, you may want to confirm resolution by sending off another cavernosal blood gas or even obtaining an ultrasound. Treatment is definitely time dependent. It's multimodal and often stepwise. Especially patients with sickle cell disease, you're going to want to kind of, you know, treat them from multiple different directions. And, you know, I like to involve the hemonc team for the sickle cell patients because they're often presenting in, you know, an acute pain crisis. And so, you know, they will want to, you know, hydrate them with oxygen and treat their pain as well. But then otherwise there's non-surgical and surgical management. So duration, as I mentioned, because it's time dependent, duration is the most significant predictor of maintenance of premorbid erectile function. So the sooner we're able to treat these patients and reverse the ischemia, the better. Although, you know, I think kind of depending on where you are, everyone kind of has different cutoff time points for what they'll do. But the exact time of irreversible findings is currently undetermined. All the papers out there kind of use different defining points. And so it's hard to kind of say, oh, it's, 17 and a half hours. There's no chance of recovering function at this point. It's, you kind of just have to take each patient individually. But what we do know is that, there are changes even as early as 6 hours where you can see smooth muscle edema and atrophy. And this has all been shown by, histological studies. Here is one example of a rabbit model that showed that at 12 hours, there's interstitial edema. At 24 hours, there's actual destruction of the sinusoidal endothelium. And then at 48 hours, there's muscle necrosis with fibroblast-like cell transformation. So, there's not just, visible changes that you see, but this is actually happening on a histological level. And then, of course, kind of looking at duration of ischemia and outcome of erectile function, basically that, essentially the longer out you get, the less likely you are to have functional erections, even with PDE5 treatment. So as I mentioned, it's like, it's every paper uses a different cutoff. For some reason, we all have to use 6, 12, 36, 24, 48 hours. But essentially, you can rest assured that the longer it is, the worse the chance is. One surprising thing in this study was just that only 5% of patients with sickle cell disease had ever been informed about the risk of sickle cell disease. So, just keep it in mind that, we are always shocked sometimes when patients show up after 36 hours with an erection, but, they're not informed about these things. So, keep that in mind and don't be judgmental. So other reports just basically supporting that the duration of ischemia correlates with worse outcomes erection-wise. That, one study looking at a cutoff time of 24 hours, that 90% of those patients, had complete erectile dysfunction after that, whereas 24 hours, another study looked at 24 hours and that 90% of them, less than that, had erections that were of good quality. So the AUA last year said clinicians should counsel all patients with persistent ischemic priapism that there is the chance of erectile dysfunction. So they very clearly here do not put any time point. And so I do think that it's, you just kind of cover yourself and just always warn patients that even if it's 7 hours, 4.5 hours, that this is always a risk. And then clinicians should counsel patients with a priapism event at more than 36 hours that the likelihood of erectile function recovery is low. So here, they did choose 36 hours, but basically the longer, the worse. Treatment options, usually, we always think about intracavernosal injections. So this is a very specific guideline for patients that have recently injected themselves with intracavernosal vasoactive agents. So obviously in my clinic, I have a lot of patients on this, and so it's common, that they'll maybe end up in the ED afterwards. And so if it's been, that's supposed to say more than 4 hours, not less, but been more than 4 hours, then you should try intracavernosal phenylephrine. And so this is specifically saying that you don't have to get fancy with treatment of this, and that you can simply just inject them with phenylephrine and they will usually respond, because basically it's the antidote of what they were using for themselves. And then there's really no role for conservative therapies. You're always told that the ED calls and they're like, oh, we give them Sudafed, it didn't work, can you please come help us out? And you're like, yes, didn't expect that to work. Thank you. But first line really should be intracavernosal phenylephrine and corporal aspiration with or without irrigation. And so, you're going to do this, 1, to treat them, and then 2, even if it's been a very long time and you don't necessarily, expect to preserve erection quality. It may just be to help relieve pain at that point. But you also may just kind of even skip this step if you know that there's going to be guaranteed erectile dysfunction and you're planning for placement of penile prosthesis. So for aspirating, you want to get intracorporal access. You know, you can do it through the glands. I think most of us just kind of do it through the base of the penis. As I mentioned, really at like 10 and 2 o'clock. And basically you want to aspirate and withdraw any of that corporal blood, and you're going to irrigate with saline. And actually cold saline is preferred, except in sickle cell patients. And so this alone has shown to resolve about a third of patients, which is not really that great, actually. Here, you know, what do we use for this? And at the end of the day, really phenylephrine is the favored medication because of the alpha-1 selective agonist. You know, because all in all, these medications can be kind of dangerous, right? You can have hypertensive effects and mediated inotropic and chronotropic effects. And so really the efficacy is due to that alpha mediated vasoconstriction. And so that's why phenylephrine is favored, because it's more selective to the alpha-1 receptor. Remember that actually phenylephrine is off-label for this purpose. How do we prepare it? I think kind of different places have different methods, whether their pharmacy kind of, you know, gives it to you already at the appropriate concentrations. I know that we have to make our own, but essentially you're going to dilute with normal saline to a concentration of anywhere from 100 to 500 micrograms. And then you're going to inject that every 3 to 5 minutes. For patients that are younger or have severe cardiovascular disease, you're going to want to use lower concentration and lower volumes. And then, as I mentioned, always hook them up to a monitor and keep track of their blood pressure and heart rate, because you can get that reflex bradycardia. Sometimes it's terrifying as you're like watching their heart rate go down. But, you know, risks of this have been acute hypertension, headache, reflex brady, palpitations, cardiac arrhythmias, and then even there's been case report of sporadic subarachnoid hemorrhages. Although I will put the caveat that with those case reports, patients have been given other medications prior to it, and so it's not really clear if it's due to the phenylephrine itself or maybe there are other medications. So there's not really clear, at least in the AUA guidelines, for the highest phenylephrine dose to give. And it's not really like clear what the dose should be each time you give. There are the clear contraindications for poorly controlled hypertension in patients with monoamine oxidase inhibitors, but I will say that the risk with monoamine oxidase inhibitors is actually more with oral phenylephrine than injectable phenylephrine, so that's not really a contraindication. So I just say that, you know, in these high-risk patients, you know, just make sure they're on the monitor. You know, you have the emergency room usually there if you need them, and maybe just start with lower doses instead in these patients. So here, this was just a study showing that phenylephrine is less efficacious in the you know, obviously the acidic environment that the compartment syndrome of ischemic priapism is, and so you do need higher doses to overcome that. And so is it safe? You know, when you inject these patients, sometimes, you know, you shock yourself, you're giving 500, 1,000, and like all of a sudden it adds up. And so this study was looking at the review of what had been used for these patients. And I was actually a resident when the study was done. And so the idea that perhaps I gave the 12,000 micrograms is terrifying. But the whole point here is that, you know, each patient may require higher doses. And ultimately, there were no documented bad side effects or complications noted from these very high levels. And then looking at admission versus discharge vitals, there was a, you know, a slight reduction in heart rate and interestingly diastolic blood pressure, but that, you know, higher doses are probably safe. You know, when you monitor appropriately, and higher doses may be required. And so, you know, overall, you know, this is safe to use this. Now, what about combining both of these efforts? So combining aspiration, irrigation, and phenylephrine versus doing them independently. As I mentioned, really just in the situation where patients had, injected vasoactivations, you can use phenylephrine alone, but usually the best outcome for like true other ischemic priapism, you want to do both efforts. And so that is shown to be the best. And then, as I mentioned, all of the aspiration, irrigation, and injections may be deferred if you are, 36 plus hours out, and ED is pretty much confirmed, and you want to move on to penile prosthesis placement. So you may skip these for concern that maybe doing all of this may put your prosthesis at risk of infection. Now, shunts, second line, basically the thought behind doing a shunt is that you create a surgical fistula between the corpora cavernosa and either the glands, the spongiosum, the dorsal vein, or the saphenous vein. And the goal is to allow, a connection between these to allow for outflow and inflow to cause detumescence. You can either do distal, proximal, bring them to the operating room, or some studies have looked at anticoagulating these patients. Really, by the guidelines, you should only be doing distal shunts with or without tunneling. And those who have failed pharmacological intracavernosal reversal and aspiration with or without irrigation. As I mentioned, proximal shunts really more historical and not the preferred method. Risks of doing this: erectile dysfunction, obviously urethral injury, infections, persistent fistulas, and necrosis and gangrene. Now, they then say that, if you just did a shunt, then you can consider additionally tunneling, where you're passing an instrument, through the corpora to try to, basically destroy that tissue. And so with tunneling, there is definitely a higher risk of erectile dysfunction after this. But, of course, we always say this, and they presented with priapism of prolonged durations. Maybe that's what caused their erectile dysfunction. What shunts are out there? Winter shunt, definitely, the simplest and easy, but the least successful. There's, I think probably the more favored one is the T-shunt, where you put a tenon blade vertically into the plant's corpora, and you rotate it laterally away from the urethra. And, with that, you can then additionally, do tunneling through that access point. And some studies have suggested up to 100% resolution, but I will give the caveat that it's probably, patient selection for doing that. So here is just a picture showing one winters with the biopsy through the glands. And then on the right is the stake maneuver of passing a dilator through the corpora. So considerations for doing distal shunts, obviously, you may not want to do this if there's concern for, a bleeding risk. May be hard to do if there's severe phimosis. You are kind of at higher risk if there's a narrow penis of, injury to the urethra. And so you may want to reconsider what size, knife you're using. And then they also give the idea of kind of tunneling with ultrasound guidance, although I would say it's probably pretty difficult to accomplish. The open distal shunts, algorabs, where you basically open a little area in the distal tunica albuginea. And this, of course, can lead to glands numbness, possible atrophy, but has a decent resolution rate. The Burnett's maneuver is a modification of the algorab, where you do the algorab and then you pass a dilator retrograde through the corpora. Of course, this can lead to wound infection, as I mentioned, skin necrosis, and possible fistulas. Really just for historical purposes in these pictures, but there's quackles, which is the shunt between the corpora cavernosa and spongiosum at the bulbar urethra, satures, which is bilateral quackles, and then there are vein and anastomosis shunt options of gray hacks and berries. So post-shunt, you can, you can see a reactive hyperemia in response to the extended hypoxic and acidic state. And generally, it should be like a painless response if the shunt remains open. There are lower post-op recovery rates of erectile function for shunt surgery, especially with prolonged erections, but that's not surprising. And I really hear, that there's higher risk of ED with proximal shunts as opposed to distal shunts, another reason to not do proximal shunts. And then at 36 hours, there's irreversibly impaired erectile tissue, both structurally and functionally. And so any shunt surgery really at this point is, again, the focus is not preserving erectile function here. It's just the focus of, reversing their pain. So overall efficacy of shunts, basically that Winters is the least successful, whereas Algarabs is probably the favored versus Winter T-shunt. And that, here is just showing that after shunt surgery, erections, are impacted by that. This is a study of 19 men who were on average 34 years old, undergoing, presented on average of 96 hours of priapism, sorry. They all ultimately had multiple different treatments in a stepwise fashion, starting with aspiration, irrigation, phenylephrine injections, and then a winter shunt, and then other possible shunts. And so basically, the outcome was that, with the shunting, of all these patients, 1/5 of these patients had complications, either high flow priapism, urethral injury, cavernocytis, or necrosis. And that only 26% of these patients had preserved erectile function. And kind of like looking within this data, that was actually probably the patients with earlier presentation. So all in all, here, after aspiration and irrigation and phenylephrine, 70% of those patients preserved erectile function with fewer after shunts and distal shunts. But again, maybe that's just overall related to their timing of presentation. As I mentioned, no evidence for oral treatment for ischemic priapism. And then, what do you do now if the shunts don't work? So if there's persistent erection following shunting, if you, as I mentioned, sometimes it can be very confusing, right? These patients have a lot of edema, they kind of have a what are you feeling penis, and you're like, I don't know if it's fixed or not. So what you can do is you can send off another blood gas, or you can even obtain a Doppler ultrasound, prior to moving on to more surgery. So here, doing those studies, the goal is to differentiate between persistent ischemia versus just kind of that reactive hyperemia, or possible very rare conversion to non-ischemic priapism. And certainly, being a tertiary medical care center, you're going to get referred patients from outside that have undergone multiple treatments. They still have concerns. And so you're going to want to start with a blood gas in those patients. Now here is where an MRI may be useful. And so, if you're considering doing a penile prosthesis as your next step, you may want to get an MRI to show if there's any viability of that smooth muscle. Now, the AUA recommends that you can consider placement of penile prosthesis in a patient with untreated acute ischemic priapism greater than 36 hours, or in those who are refractory to shunting with or without tunneling. So the purpose of doing a prosthesis at this point is that, one, obviously when you put your dilators through, you're going to provide detumescence. You are ultimately going to relieve pain by relieving that compartment syndrome. And by doing it early, you may preserve penile length. Obviously, they would then be able to return to sexual activity. And satisfaction is actually pretty high after doing this, with the caveat that infection rate is pretty high doing this. So, seeing an infection rate of 10% is very scary. And then the risk of distal erosion or perforation, especially if they've previously undergone, irrigation aspiration or some sort of distal shunt. So immediate penile prosthesis placement. Typically most surgeons will start with a malleable and then potentially replace out for an inflatable later on. And so why do this? As I mentioned, obviously the goal is to treat the priapism at that point. Doing it earlier is technically easier because at that point, that the scarring and the fibrosis has not really set in if you're delaying implantation. And you can preserve penile length and loss of girth. And obviously, you're treating their inevitable ED early at this point. Reasons to not do it is, the patient is presenting in an acute crisis. Are they able to consent to a big procedure like that? And, it's still overall okay to do a delayed penile prosthesis placement. You may go back after like 6 weeks and still potentially protect preservation of length and girth and, minimal risks overall. So, the other thing to keep in mind is that, not all hospitals can also on demand put in a penile prosthesis because most hospitals don't have prostheses on their shelves, right? You're calling in a rep to bring this in. So if it's 4 o'clock in the morning, and your rep lives 3 hours away, is this a reality? So for most hospitals, no, but at centers where they do this a lot, they'll have this stocked. So again, here's just one study looking at early placement of malleables, and basically, pretty high overall satisfaction rate for doing this. Of 10 patients that initially had a malleable placed, they all then went on to have it replaced with the inflatable, with a even higher satisfaction after that. And, as with most remove replaces, they were able to upsize on the replacement. That's always like patients' fear of losing more length. So immediate insertion of penile prosthesis. Here, they were looking at 50 men who ultimately had malleables or inflatables. And interestingly here, there were more infections in the malleables and none reported in the inflatables. But ultimately, 30% of patients underwent revision surgery, but that did include the patients who electively wanted to exchange to inflatables. And no patients here reported penile pain or shortening after doing this. And then, that's a pretty great satisfaction rate of 96% for doing this. Now, again, here, this is just looking at immediate versus delayed. And really, what they found to be statistically significant is that doing it earlier helped preserve penile shortening, increased satisfaction, and higher revision rates actually for doing it in a delayed fashion. Just quickly about the European guidelines, they were a bit ahead of us. As early as 2014, they were saying do a distal shunt and then a proximal shunt, although they were also questioning the efficacy of proximal shunts. And they, in 2014, said that if there's a priapism greater than 36 hours, that you can consider placing a penile prosthesis. Ultimately, this will be up to, the surgeon on call, what they're comfortable with doing, but this is, a viable option. You're going to consider a penile prosthesis if it's more than 36 hours, if they failed other treatments. And then actually, even in 2014, they also suggested using an MRI prior to surgery, if there's any questions, about what you should be doing. So some thoughts on ischemic priapism. MRI can provide an accurate assessment of smooth muscle viability in ischemic priapism. Penile shunts, I think, kind of limited data on penile shunts. That is unfortunately, the priapism data in general, all of it is pretty limited, usually single institution and retrospective. But you know, there can be bad outcomes for shunts. And you know, also depends on the comfort level of the resident and the attending as well for what they're willing to do. And then penile prosthesis, limited data, but a good option if you're comfortable doing this. So back to the emergency room. You put the patient on a monitor, you injected him simply with 500 units of diluted phenylephrine, and he had complete detumescence and was very happy. You told him to stop taking trazodone and go discuss that with a psychiatrist. He was discharged home. And so in conclusion, you know, you want to obtain an appropriate history exam, lab work, imaging, if indicated. Make sure you always send off a corporal blood gas, and then always counsel patients through the risk of erectile dysfunction, and that, you know, you're really there to relieve their pain and bring them to a flaccid state. And then, you know, you're going to base your treatment on what the duration of, you know, their presentation is, and, you know, any other kind of factors that might affect what you would potentially be treating them for. And then, you know, consider malleable placement early. Thank you.
Thanks for that really comprehensive update. So one question I always have, or you know, subjective assessment is, you know, how soft is soft enough? Where, you know, the residents say we got them down to 40%. You know, it's percentage is subjective, but like, what are there any specific more objective assessments or signs that we can have where this is, we're in a safe place, because we never get them fully flat?
Right. So I mean, in that sense, sending off another blood gas. And even if you're really suspicious of persistent ischemia, get an ultrasound if possible. Yeah, I mean, actually yesterday morning, a resident called me and I was like, oh my God, I'm not gonna call, but you know, a patient had been drugged by his friends with Cialis 2 nights before and came in with erection for 28 hours. And they were pretty aggressive in doing aspiration, irrigation, and phenylephrine, and he would respond immediately. And then we kind of just fill right back up. And ultimately, they actually sent him home. And I was like, okay, well, you probably should have gotten an ultrasound, and they did get another blood gas that was suggestive of return toward venous, but not perfect. And so that's why they ultimately sent him home. And so I was like, the only other thing you could have done was get an ultrasound. I was like, well, please call him now and make sure that he's okay. And I think it was just so that Cialis was still in the system. And so he was actually doing better later that day. So I would say blood gas or ultrasound if you're really concerned. Yes.
Thanks for a nice talk. Regarding sickle cell, what's your standard protocol for me? You know, the question always is you try the you know, non. I mean, I guess what I'm asking is, when do you go to injection versus trying some of the other non-injection therapies, i.e., hydration, oxygenation, alkalinization, et cetera? And what's your protocol?
So my protocol is to involve hem-onc early so that they are kind of addressing the hydration, pain control. And then we are also just going at them from the aspiration, irrigation, injection standpoint.
Did you do that early, or should you wait for some of those?
No, you do it early.
Even in those patients?
Yeah, even in those patients. Just because, again, duration of these ischemic events kind of ultimately, you know, down the line will lead to, you know, erectile dysfunction. And so I think the hardest patients are the recurrent ones that you know. And you're even amazed that, you know, by the 10th presentation that they are even getting erections at all. And so, you know, actually in those patients, I've had the conversation of putting in a prosthesis earlier when it just keeps happening.
Just one more.
Yeah.
So the main argument against proximal shunts is complications and or lack of efficacy, or both?
Both, and also surgeon comfort level, right? So I mean, I personally have never done a proximal shunt, and so I would say that, you know, with the fact that in increased risk of poor outcomes, that I'm not gonna, go to that.
And so it's a great talk. One of the things that comes up along with what Peru said was just like when is good enough. Maybe go back to the slide that had the Sudafed, phenylephrine, the when graph, because it looked, from BU, we're always taught that the corporal physiology, this is a medical disease, not a surgical disease. And if you go back to this graph, it looks at how the smooth muscle reacts at different pHs. And to answer your question, I'll use a lot, I think, but it was a graph with how the smooth muscle reacts.
Oh,
right there, right?
Yeah.
Yeah. So do you ever use like phenylephrine post-procedure? Because I kind of talked to the residents about giving phenylephrine after a shunt when they're maybe 70 to 80% hard. Because if you look at this graph, you can see that the smooth muscle doesn't react as well at 6.9 as it does at 7.2. But the smooth muscle is still reacting, as if it's 6.9, even though it's only 70 to 80%. So I don't know if you have any thoughts about using phenylephrine after the procedure to kind of maintain that smooth muscle from recontracting or
I think that's a great idea, because you're right. Hopefully after doing the shunt, you will have improved the acidosis a bit, so that now the phenylephrine will be more effective. I haven't tried that, but I will next time.
And I think the MRI is a great idea too. Anyone who wants to put in an implant, I think that's a great point that you made.
Yeah.
I haven't really thought about that, but it just documents the fact that if you're going to put an implant in, you know that there's no flow. I think that's important.
It seems like there's a tipping point where this becomes less of an emergency and more of like a.
Yeah, that's also a great point.
Like, do you recommend then saying like you've done your aspiration, irrigation, phenylephrine, some form of distal shunt, and it's not working, and it's like, all right, the endourologist can back off and like when Stan's available, he can come in and put it in the prosthesis.
Yeah, no, I think that is also a very viable option. If you're not comfortable putting in the prosthesis, then at that point, my focus becomes pain control, and just making sure patients are comfortable. And I have definitely sent patients home. Like I remember as a resident, after 96 hours, not responding to anything. And so they went home with pain control and then came back to have a scheduled prosthesis placed. But obviously at that point it's pain control and just making sure they're comfortable. You may have to watch them in the hospital for a night or two. But yes.
Great thought. Thank you for coming. So two questions. One, you're talking about going through the corporal body. Some people advocate going through the glands because essentially you're doing a winter shunt. If you're kind of making that approach, you're kind of already jumping on the shunt aspect of it. What do you think about that?
I think, I've tried that approach before, but I've never had the winter shunt approach stay open. As soon as you pull that needle out, even when it's, a huge gauge needle, I've just never had it stay open. So you can try it. Yeah. I don't think it's going to be any more harmful than doing, a proximal access.
And early on, you kind of introduced stuttering priapism, but you didn't really talk much about what are you kind of at the advocacy of giving them some sort of blockers that don't get erections? You give them, PD5 inhibitors. I actually had a patient from Europe who was given his own injections, which very few of us send folks home with their own prescription for phenylephrine.
Yeah, you really have to have a very dependable patient for the phenylephrine. We had pretty good success, when you have a dependable patient who's comfortable with injections, and is informed enough about their physiology that they can do that. So I think it's good for the right patient, but there is a lot of teaching involved with that. And so I actually have several sickle cell patients who use that method. And then otherwise, there's the stuttering priapism is like a whole nother talk. But within the sickle cell population, there's thought to be also dysregulation of PD5. And so there's some evidence that putting these patients on daily tadalafil may be helpful for them. But then otherwise, we've used ketoconazole in these patients, have to monitor their liver function while on that. But the reason we use a lot of that IPU is it's a cheaper medication that these patients can get. Whereas, the anti-androgens, the Lupron and everything is more expensive and sometimes hard to get covered. But, a good option. And, surprisingly, you have to monitor their hormones while they're on that. And sometimes you can get them to a sweet spot where you're preventing the ischemic events, but they're still able to have normal erections and normal sexual activity. But it's hard. Those patients are very hard.
We actually have 2 questions from our Zoom. So the first one is, what is your preferred benefit for prevention of stuttering priapism?
For me, as I just said, it's pretty patient specific. And so it is really a combination of any of those, depending on what the situation is.
The second is there a role for aspirin and clopidogrel in priapism management?
So that's asking about anticoagulation. And so really the studies have not shown to be supportive of doing that.
Hi, thank you. From a process standpoint, it sounds like the inject first, and you usually do like 500 mics in an ml, or
Yeah,
everybody does a little different.
usually I concentrate 1,000 into 1 cc.
Okay.
And just because I also, I don't always want to inject high volumes, because obviously if you're injecting a higher volume into an already, very confined space, it's going to cause them more pain. So I tried to use like half a cc at a time.
And then, the butterflies are nice because they stay in place. I find that angiogas, I hadn't used one before, and we had one several months ago, and it's painful because once if you're trying to aspirate, once it stops, you can't use it anymore. So this poor guy, little hematoma, I felt really bad, when we had to aspirate again.
Yeah.
So
I know. And now, we used to always have the problem that there's more safety mechanisms on the butterfly needles that you just touch them, it immediately retracts. And so we used to have I don't know, probably a legal box of the ones that didn't retract. But
what pH do you, I'm sorry.
With one of those people.
Yeah, it would not fun. And we would touch, who was I with? Was it Tyson? Oh my gosh, we touch the butterfly and retract. I was like, what is happening?
I'm trying to teach the residents. I put in a 16 gauge and then I set up a stopcock.
Yeah.
And then I have phenylephrine coming in on one side, aspiration on the other, and then a normal saline chaser, because sometimes it's hard to get that 0.5
Yeah.
phenylephrine. Half of it is still in the tubing of the
Right.
butterfly. So
That's
chase
fair.
it with a little normal saline.
But
I feel like I'm an anesthesiologist.
Old-fashioned butterfly. Yeah.
don't you want to irrigate first? Kind of goes with your argument. You don't first, you irrigate first, right?
Well,
Then you get the
aspirate
pH,
first.
Aspirate first.
Yeah. Right.
that's where
so
the
you
ABG
start
is
with-
good. The ABG is a little cheap aspiration. And
Yeah,
I
it's the right pH then.
take out as much as possible.
We used to use the chemo port access needles. It's on a 90-degree angle. That's short. That's and it doesn't.
Thanks very much.